Hi, my name is Quyen from HelpAge International. Welcome to my presentation on an innovative and affordable community-led approach providing comprehensive community-based care in Vietnam. My presentation will be in 5 parts, which aim to show how low and low middle income countries can partner with communities to take lead in the community-based care service with the resource that the country has. Part 1. Population Aging. Vietnam is rapidly aging and has one of the shortest transition periods from aging 10% to age 20%. In fact, it's faster than China or Japan. Non-communicable diseases or NCD is also expected to increase with rapid aging. By 2026, NCD will account for more than 75% of morbidities and more than 80% of all mortalities in Vietnam. More than 75% of these NCD deaths will be in older people, the fastest growing age group in Vietnam. Despite increasing healthcare needs of the aging population, most countries in the region have limited resources to expand their social and health service and make them more affordable and attractive. Expensive institutional care for older people that are found in affluent countries is an option for only a tiny minority in most developing countries. Taking the learning from Japan by rethinking aging and dependency. In 1950, older people aged 65 years and above made up around 8% of the country population. By 2020, the percent of older people has increased to close to 40%, and by 2050 will make up around 50%. This is a major concern for Japan. However, taking a closer look at the linkage between aging and dependency, not all older people are dependent, and likewise, not all young people are independent. The dark blue highlights the actual number of people that are dependent. Therefore, by investing in healthy and active aging, older people can remain healthy and active, which will reduce the number and percentage of older people being dependent. This is the most cost-effective, affordable, and doable way to create an ageless society that other countries can adopt and adapt. We need to change our long-held understanding that increase in older people means increased burden. We need to see population aging as an invaluable resource if they are included and invested. This table shows long-term care needs of older people in one sub-district in Thailand and 2 communes in Vietnam. All older people aged 60 years and above were surveyed. The data shows more than 90% of older people were independent, had no ADL or IADL difficulties. 7.5% were considered as housebound, having some minor ADL and IADL difficulties. Only 1.4% were in the bedbound group, which had high ADL and IADL difficulties. The last group, making up of less than 1%, were the palliative care group, which required intensive care support. Part 2, the Intergenerational Self-Help Club Model, or the ISHC. The ISHC development model is a development initiative that provides control of development process, resources, and decision-making authority directly to the community group. The underlying assumption of the ISHC development models are that the communities are the best judge on how their life can be improved, and if provided with adequate training, information, opportunities, and resources, they can organize themselves to provide for their immediate and long-term need and development. Moreover, the ISHC development model is motivated by their trust in people, and hence it advocates people's full participation and ownership as a powerful force for development. By treating people as an asset and partners in the development process, which will make the model be more responsive to local demand, is more inclusive and cost-effective compared to traditional development models. The ISHC development model is cost-effective and affordable for low and low-middle income countries like Vietnam. It is attractive for young and old, men and women, poor and non-poor. It is dynamic, is suitable for rural, urban, coastal, delta, and mountainous areas. It is replicable, as evidenced by its rapid growth throughout the country. It is sustainable, able to continue to operate and grow even after the funding ends. It is multifunctional, which enables it to meet the wide range of needs and wants of both the young and old. A typical ISHC has 8 to 12 component or activities, which is based on the top need of its and community members. However, today we will focus in more detail component 4, community-based care. Part 3, the comprehensive community-based care service of the ISHC, which aim to enhance community capacity to take care of themselves. There is a growing concern that there will be a large reduction in traditional care provider due to migration of young adults to urban areas in the countries or abroad. However, looking at primary and secondary data shows that there is also a large migration of near-old and old moving back to the rural community due to mostly high cost of living in urban areas and unhealthy and non-age-friendly cities. With proper inclusion and investment, these near-old and old can be a big source for the country to take care of the increasing number of people needing care. In addition, looking closely at the 2019 data, the number and percentage of older people, especially near-old and young old, will continue to rapidly grow in the next 30 to 40 years. From HelpAge International in Vietnam, Vivian, working with thousands of ISSCs and communities in the countries, for every one person that needs care, there are 50 people who can provide the care if they were properly trained and supported. This is the ISSC Community-Based Care Management System. First, we need to look at the ISSC organization structure. The ISHC is managed by a club management board consisting of 5 to 6 members. One of the club management board members will be in charge of the community-based care component. Under the club management board are the 50 to 70 members. To promote greater participation and ownership, the members are divided into smaller neighborhood groups. Each group has their own group leaders. The club management board members in charge of the community-based care component is the care manager. For social and personal care, care manager will work with at least 10 home care volunteers. 2 to 3 home care volunteers will take care of one care client. For living support needs of the care client, the care manager will work with the ISHCs and local authorities and communities to provide this care. For health and medical care, the care manager will work with the health provider from the local commune health station or retired health professional in the communities. The ISHC community-based care component consists of 4 different types of care. The first care is the social care, which will be provided by the home care volunteers, which consists of befriending, providing information or updates on what is happening in the community, escort service to market, temples, visit friends and families, attend local social, sport and cultural events, singing, poetry, hobbies, and other activities. Second is the personal care, which is also provided by the home care volunteers. First, housework. Second, food preparation and feeding. Third, massage and simple rehab. Fourth, personal hygiene such as bathing, toiletry, dressing and grooming, and other. Third, living support care, which are mainly done by the ISSCs and local communities. First, financial support. Second, access to rights and entitlement. Third, house repairs and improvement. Fourth, gardening, farming, labor support. Fifth, in-kind donation, clothing, house utensils, and others. And sixth, assistive device like walking stick, wheelchair, eyeglasses, and others. The last is the healthcare, which is provided by the health provider from the local commune health station, like provide health information, health screenings, health checkup, and medical-related referrals, health insurance, and others. Now, let's look at the care management information and record system, which consists of 4 parts. Part 1 is the general care client and care provider information, which will have information on the care client, healthcare providers, and the home care volunteers. Part 2 is the general situation of the care client, which cover housing information, income information, health status information, and others. At the bottom is the NCD information. Part 3 is the ADL and the IADL section, which has the care client ADL scores and the IADL scores. The last part is the care needs and gap section, which look at the care needs of the care client, what is being provided, and what are the gaps, and who and how will the care gap be met. Results and impact. By the end of 2022, there are more than 5,400 ISHC spread out in all 63 provinces and cities in the country. The ISHC has become the largest community-based care provider in the country, with more than 28,000 home care volunteers taking care of at least 15,000 care clients annually. With the new Prime Minister Decision 1336, which target at least 3,000 new ISSC by the end of 2025, the number of home care volunteers and care clients will continue to grow. Thank you.